Okay, so up until now we were studying anal canal anatomy and we had finished with it. So the topic was anal cancer and we were studying from this ASCRS textbook of colorectal surgery, and anatomy was done. So now we continue with squamous cell carcinoma of the anal canal. Okay, so we are starting with squamous cell carcinoma of anal canal. Squamous cell carcinoma. Okay, so in the USA, the median age of diagnosis is 60 to 65 years. So it might be that around the world too. And there is slightly higher incidence in the women. Slightly higher incidence in the women. So, symptoms. Approximately 1/3 of patients with squamous cell anal cancer are asymptomatic. So, 1/3 patients are asymptomatic or have non-specific symptoms on presentation. Clinical manifestations of anal canal tumors are mainly related to tumor size and extent of infiltration. Tumor size and extent of infiltration. So, the 1/3 of the patients are asymptomatic. Let's note down important points. Yes. Median age would be 60 to 65 years. Median age is around 60 to 65 years. Slightly higher predisposition in women. Higher in women. Then we come to symptomatology. Symptoms. So symptoms में around 1/3 are asymptomatic. Or have non-specific symptoms. Or non-specific symptoms. 1/3 are asymptomatic or have non-specific symptoms. So clinical symptoms, they depends on tumor size and extent of infiltration. Number 1 is tumor size. Number 2 is extent of infiltration. The most common symptom is rectal bleeding, which is seen in approximately 45% of cases. So most common symptom is rectal bleeding. Most common symptom is rectal bleeding. And it is seen in approximately 45% of the cases. Followed by anal pain or sensation of anal mass. Followed by anal pain or sensation of anal mass, seen in 30%. Anal pain or sensation of anal mass. Around 30%. Sensation of anal mass in around 30%. Other symptoms are anal pruritus, discomfort in sitting, change in bowel habits, incontinence due to tumor infiltration into sphincter. Incontinence, if there is incontinence, it means that there is tumor infiltration into the sphincter. Discharge, bleeding, fissure, fistula. So these are some other symptoms. So let us note down all the symptoms. Other symptoms would be anal pruritus, discomfort in sitting, change in bowel habits, incontinence, which means that there is involvement of sphincters. Then there is discharge, bleeding, fissure or fistula. Discharge, anal discharge, bleeding, we have written already, fissure and fistula. Diagnosis may be delayed because initial symptoms are non-specific and the anal canal is often a difficult location for examination. Moreover, because anal cancer is rare, many primary care practitioners have little experience in diagnosing it. So it can be diagnosis can be delayed. It is a rare thing. The clinical diagnosis of anal tumor should be confirmed by histologic examination. Should be confirmed by histologic examination. A forceps or needle biopsy may be done to establish the diagnosis. Forceps or needle biopsy may be done to establish the diagnosis. So next one would be, for diagnosis we need histopathological confirmation, and that means forceps or needle biopsy. Forceps or needle biopsy. It is very important to document an exact description of location and appearance of the biopsy site. So it is important to document exact description of location and appearance of the biopsy site, as this will help in planning radiation fields and post-treatment surveillance. Radiation fields and post-treatment surveillance. So while doing biopsy, what we have to do, document location and appearance of biopsy site. Document location and appearance of biopsy site. If the lesion is large or involves the sphincter, and excisional biopsy is advisable. The lesion is large or involves the sphincter, then an excisional biopsy is inadvisable because the subsequent wound healing may delay optimal chemoradiation treatment. CRT. Enlarged lymph nodes may be excisional biopsy with needle aspiration under radiological guidance. So in large lesions or sphincter involvement, excisional biopsy inadvisable. And why is it inadvisable? Due to delayed wound healing, delaying optimal CRT. Delayed wound healing, due to which delayed CRT, chemoradiation treatment. So examination. Detailed physical examination is very important as a lesion in the anal canal may be easily missed on cursory exam. Physical examination includes inspection to assess for the tumor location. First we need to inspect to assess for tumor location, size and extent, and direct visualization of the mass via anoscopy, rigid proctoscopy, or flexible sigmoidoscopy, which may be retroflexed in the rectum. Digital rectal examination should be done to assess sphincter function and the relation of tumor to the sphincter. Digital rectal examination to assess the sphincter function, relation of tumor to the sphincter. So next we write about examination. Examination point number 1 would be inspection, as always. So in inspection we need to assess for tumor location. We need to look for size, and then we need to look for extent. Location, size and extent, inspection. And tools for inspection would be anoscopy, rigid proctoscopy, flexible sigmoidoscopy. And on flexible sigmoidoscopy, how would we assess the mass? By retroflexing in rectum. In flexible sigmoidoscopy, we will retroflex in rectum. So anoscopy, rigid proctoscopy, and flexible sigmoidoscopy. And in flexible sigmoidoscopy, we will retroflex in rectum. And then what we ought to do is DRE, digital rectal exam, which is very important in all anal pathologies. Digital rectal examination. In digital rectal examination, we need to assess sphincter function, and relation of tumor to sphincter. The tumor may present as a small ulcer or fissure with slightly exophytic and indurated margins. Small ulcer or fissure with slightly exophytic and indurated margins. The tumor may present like a small ulcer or a fissure with slightly exophytic and indurated margins and irregular thickening of anal canal. So presentation would be presentation may be like a small ulcer or fissure like a small ulcer or fissure with indurated margins and irregular thickening of anal canal. If a thorough anal canal examination is not possible due to significant perianal pain or spasm, examination under anesthesia may be done to assess the tumor. So examination under anesthesia is another possibility if examination is not possible. So if examination not possible due to pain or spasm, then what we do is examination under anesthesia. Along with local examination of anal canal, groin lymph nodes should be examined to rule out involvement. So groin lymph nodes should be examined to rule out involvement. So point number 6 should be examine groin lymph nodes. It has been traditionally recommended that patients with an anal cancer should undergo colonoscopy to evaluate for synchronous colorectal lesions. However, it should be noted that there are no definitive data demonstrating an association between squamous cell anal cancer and adenomatous neoplasia of colon or rectum. So, traditionally recommended that patients in anal cancer should undergo colonoscopy. Traditionally colonoscopy recommended. In women with anal cancer, a pelvic examination may be performed to determine the extent of invasion of an anterior lesion into the posterior vagina. So, pelvic examination to be done in women with anal cancer. Female patients should have routine gynae examination given the risk of other HPV-associated diseases such as cervical dysplasia. So, in female patients, pelvic examination should be done. And for what? To rule out extent of invasion into an anterior lesion into the posterior vagina. Investigation. Treatment of anal cancer is based on the stage of tumor. Therefore, a comprehensive physical exam should be complemented with imaging to determine the possibility of loco-regional or systemic spread. So, investigation of choice for loco-regional staging is MRI of the rectum, pelvis with or without endoscopic ultrasound. With or without endoscopic ultrasound. And distant metastasis में we do CT scan of the chest, abdomen or pelvis or FDG PET CT. So clear cut it is written what imaging we should do. So examination part is over. Now we come to imaging. imaging. So for loco-regional staging, what we must do is MRI of rectum and pelvis with or without endoscopic ultrasound, with or without endoscopic ultrasound. This is loco-regional staging. And if there is suspicion of distant metastasis, or rather to look out for distant metastasis, we must do CT chest, abdomen or pelvis, CT chest, abdomen or pelvis, or we can do FDG, PET, CT. So these are the imaging. These are the only imaging we need to do. So MRI of the rectum pelvis. MRI provides a high resolution multiplanar information regarding the location, size, circumferential, craniocaudal extent of the primary tumor. So when looking in an MRI, what we must see is location, the size, circumferential involvement, craniocaudal extent of the primary tumor, involvement of adjacent structures including the sphincter. Sensitivity of MRI in identifying squamous cell adenocarcinoma has been reported to approach 90 to 100%. So sensitivity of MRI in identifying squamous cell anal cancer is approximately 90 to 100%. Along with evaluation of the primary tumor, MRI can be used to assess involvement of the pelvis and inguinal lymph nodes. What we also see is pelvis and inguinal lymph nodes. MRI determines lymph node involvement based on various criteria such as lymph node size, loss of normal bean-shaped morphology and fatty hilum, internal T1 and T2 signal heterogeneity with central necrosis and inhomogeneous enhancement. So how will we know that a lymph node is involved? So lymph node involvement can be seen while assessing the lymph node size. There is loss of normal bean-shaped morphology and lymph nodes become more round. There is loss of fatty hilum, internal T1 and T2, signal heterogeneity with central necrosis and inhomogeneous enhancement. Short axis threshold values of 8 mm, 5 mm and 10 mm have been registered for pelvic, perirectal and inguinal lymph nodes respectively. So short axis threshold values of 8 mm, 5 mm, 10 mm have been suggested for pelvic, perirectal and inguinal lymph nodes respectively. Okay. So on MRI, along with other aspects, we see lymph node involvement. MRI lymph node assessment. Oh, it's badly written. MRI lymph node evaluation. So how will we know that it is involved? Lymph node size. So short axis threshold values are for pelvis, it is 8 mm, perirectal it is 5 mm, and inguinal lymph nodes it is 10 mm. Pelvis, perirectal and inguinal lymph node size 8 mm, 5 mm and 10 mm. Then loss of normal bean shape. There will be loss of fatty hilum. There will be central necrosis, inhomogeneous enhancement. central necrosis, inhomogeneous enhancement. So now transanal endoscopic ultrasound. Transanal endoscopic ultrasound is used to assess local staging of anal cancer. So it is used to assess local staging of anal cancer. This modality may be superior to MRI in evaluating small superficial tumors. So it is superior to MRI in evaluating smaller superficial tumors. However, the limitations of transanal endoscopic ultrasound include an inability to ascertain involvement of proximal pelvis or groin lymph nodes, and it may be difficult to use in assessing a stenotic or painful anal lesion. Lastly, its accuracy is highly operator dependent. So the accuracy is highly operator dependent, and smaller tumors it can recognize more easily, and it cannot ascertain involvement of proximal pelvic lymph nodes, groin lymph nodes, and it may be difficult to use in assessing a stenotic or painful anal lesion. Then let us see this flow chart. So it's a good flow chart. Anal mass. So when a patient with anal mass comes, we take a detailed history including sexual history, physical examination including DRE and proctoscopy, gynecological examination females, tissue biopsy to prove anal cancer. Then what we do is staging of anal cancer. Loco-regional में we do MRI plus minus endoscopic US. Systemic staging में we do CT, chest, abdomen and pelvis or PET scan. And then we do colonoscopy to rule out any other colorectal cancer. And then treatment is done based on TNM staging. So this is a basic algorithm for anal mass evaluation and workup. So we would have to draw this algorithm. Let us note down this algorithm. It's a very good one. Algorithm for workup. So we have a patient with anal mass. We take a detailed history. Including sexual history. Then we do physical examination including DRE and proctoscopy. We take a detailed history, we do physical examination. And it includes gynecological examination in females. And then we do tissue biopsy to prove anal cancer. Tissue biopsy to prove anal cancer. Then we do staging of anal cancer. So in staging there is two types, loco-regional staging and systemic staging. So we do loco-regional staging by using MRI plus minus endoscopic ultrasound, and we do systemic staging by CT, chest, abdomen and pelvis, and plus minus PET scan, and colonoscopy to rule out any other colorectal cancer. To rule out any other colorectal cancer. and then we can start treatment according to based on TNM staging. Okay, so let us look at these pictures. So this is figure which shows an anal cancer pre-treatment MRI T2. So water is white on T2, oblique suspicion for focal tumor invasion into the right lateral internal anal sphincter, green arrow. So this is some suspicion for growth, and this is transanal endoscopic ultrasound view to assess the staging of anal cancer, and this is of course the PET CT. Left inguinal adenopathy and mesorectal adenopathy is seen in this image. And shall see FDG PET CT. So approximately 98% of anal tumors are FDG avid. Hence, FDG PET CT has assumed an increasing role in staging and assessment of treatment response. PET CT may be used to evaluate primary tumor size, lymph node status, and distant metastasis, and may help in planning radiation therapy by clearly defining the site of metabolically active tumor. How do we plan radiation therapy? By clearly defining the site of metabolically active tumor. Used in post-treatment surveillance. PET CT is indicated for node positive and T2 to T4 anal canal and anal margin cancer to verify staging before treatment. So it is indicated for node positive and T2 to T4 anal canal and anal margin cancer to verify staging before treatment. Become part of the standard workup, particularly for evaluating lymph nodes that appear ambiguous in CT to aid in management and to serve as a pre-treatment baseline. Sensitivity of more than 90% and specificity of 80%. PET CT has been shown to alter the staging of anal carcinoma in approximately 20% of cases and treatment intent in approximately 3 to 5%. The main impact of PET CT on treat therapy stems from its superiority in detecting involved pelvic or inguinal nodes, prompting the radiation oncologist to include these in the radiotherapy field. So it is superior in detecting involved pelvic or inguinal nodes. PET CT has also impacted post-treatment management in 18% of patients. It may confirm persistence of disease or local recurrence and influence decision making. Regarding the use of chemotherapy in patients with metastatic disease, the high negative predictive value of PET CT may dictate avoidance of unnecessary biopsy after chemoradiotherapy. Has a high negative predictive value. So about PET CT. So first point we learned was that 98% are FDG avid. 98% are FDG avid, and indicated for node positive and T2 to T4 anal canal and anal margin tumor. Anal canal or margin tumor. So node positive, T2 to T4 anal canal or margin tumor. And talking about sensitivity of more than 90%, specificity of 80%. So it is superior in detecting lymph nodes, pelvic or inguinal nodes. Has a high negative predictive value. So now summary of initial workup of anal cancer. In the setting of a T1 tumor after a thorough physical exam, MRI of the rectum, pelvis or transanal endoscopic ultrasound may be used for additional local staging. In the absence of nodal disease, a CT scan of chest and abdomen may be used for distant. So in the setting of T1 tumor, after a thorough physical exam, MRI of the rectum, pelvis or transanal endoscopic ultrasound may be used for additional local staging. In the absence of nodal disease, a CT scan of chest and abdomen may be used for distant staging. And in the setting of a T2 to T4 tumor or node positive anal canal cancer, PET-CT may be used in addition to MRI or transanal endoscopic ultrasound to screen for distant metastasis, to assess response to CRT, and as a tool in subsequent cancer surveillance. So next we come to treatment. So let us come to the most important part, which is the treatment. So until 3 decades ago, abdominoperineal resection of the rectosigmoid and anus was the preferred surgical procedure for most cancers of the anal canal. So what they used to do was abdominoperineal resection, or APR. This radical operation was performed in order to achieve adequate margins of resection. Local resection was done for smaller lesions. And if the lesion was small, so local resection was done. Surgical treatment alone was associated with local failure in this much of cases. Early tumors could be cured by APR with 5-year survival rate of 50 to 70%. However, APR entails a permanent intestinal stoma. So the problem with APR is a permanent intestinal stoma and is associated with substantial morbidity. Over the last 3 decades, there has been significant change in the management of epidermoid and carcinomas, with more patients undergoing non-surgical treatment. So evolution of the management of anal cancer. Radiotherapy. Doses of radiotherapy varies based on the size of the tumor and presence of suspected lymph node involvement. So it varies based on size of tumor and presence of suspected lymph node involvement. In general, larger cancers require higher doses of radiation. So in general, larger cancers require higher doses of radiation. The database of RTOG 9811 trial suggests that size more than 5 cm is a poor prognostic factor. Doses in the range of 30 GY with concurrent mitomycin C and 5-fluorouracil have been shown to control small tumors and subclinical disease effectively. Doses in the range of 30 GY with concurrent mitomycin C and 5-fluorouracil have been shown to control small tumors. Preliminary results of Accord 3 trial compared 45 GY in 25 patients plus a 15 GY boost with a higher dose, but found no benefits in CFS and higher toxicity at more than 59 GY. So 30 GY was adequate. Similar results were reported in this another trial. Patients with squamous cell anal cancer received a minimum radiotherapy dose of 45 GY to the primary cancer. Recommended initial dose is 30.6 GY to the pelvis, anus, perineum and inguinal nodes, following initial dose of 30.6 GY. So the recommended initial dose is 30.6 GY to the pelvis, anus, perineum and inguinal nodes. Following initial dose of 30.6 GY, field of radiation should be reduced from the L5 to S1 junction to bottom of sacroiliac joints. Without nodal metastasis, inguinal nodes are not included in the radiation field after 36 GY. So in patients with nodal metastasis included in the radiation field after 36 GY, patient disease clinically staged as node positive for T3 T4 or with T2 residual disease after 45 GY should receive an additional boost of 9 to 14 GY. So if clinically staged as node positive or T3 to T4 or with T2 residual disease after 45 GY should receive an additional boost of 9 to 14 GY. Field of radiotherapy. So multi-field techniques with super voltage radiation, photon energy of this much, are used to deliver a minimum dose of 45 GY in 1.8 GY fractions, 25 fractions over 5 weeks to the primary cancer. The RTOG panel established 3 elective clinical target volume areas. CTV-A targets the perirectal. So 3 elective clinical target volume areas. CTV-A targets the perirectal, presacral and internal iliac regions. CTV-B targets the iliac lymph nodes and CTV-C targets the inguinal lymph nodes. Inclusion of all is recommended in radiotherapy for anal cancer. The superior field border includes the rectosigmoid junction. The inferior border includes the anus. Superior field border includes the rectosigmoid junction, L5 to S1 junction. Inferior border includes the anus with a minimum 2.5 cm margin around the anus and tumor. Lateral border includes the lateral inguinal nodes based on the imaging or body landmarks. Attempt should be made to reduce the dose to the femoral heads. Reduce the dose to the femoral heads. So this is radiotherapy. So number one, we should discuss about radiotherapy. Radiotherapy doses would vary based on size and presence of suspected lymph node involvement. So point number one is that dosage varies based on size and lymph node involvement. So in general, larger cancers require higher dose of radiation. Larger cancer means larger dose, and size of more than 5 centimeter is poor prognosis. And the recommended initial dose is 30.6 GY. To pelvis, anus, perineum and inguinal nodes. To pelvis, anus, perineum and inguinal nodes. And inguinal nodes are in patients with nodal metastasis. Inguinal nodes not included after 36 GY. Inguinal nodes not included in radiation field after 36 GY. So fields of radiotherapy we will write. Next point is fields of radiotherapy. So we have, let's take a break now. So we have CTVA. CTVA is clinical target volume. So CTVA targets the perirectal, presacral, and third is internal iliac regions. So CTVA, clinical target volume, A targets perirectal, presacral and internal iliac regions. Then we have CTVB. Second is clinical target volume B, and it is targeting internal iliac lymph nodes. Then we have CTVC. It targets the inguinal lymph nodes. Inclusion of all is recommended in the radiotherapy for anal cancer. Inclusion of all in radiotherapy recommended. So the next point is the field borders. So field borders are superiorly it is the rectosigmoid junction. Inferior border is anus. The minimum 2.5 centimeter margin around the anus and tumor. The minimum 2.5 centimeter margin around the anus and tumor. And lateral borders are the lateral inguinal nodes. So these are the field borders, and we have to reduce the dose to the femoral heads. So star point would be to reduce dose to femoral head. So short-term side effects are, we have short-term side effects. These are dermatitis, temporary anal swelling and pain, frequency and urgency, nausea, weakness, vaginal discomfort and discharge. And these side effects often improve after radiation stops. And long-term side effects are anal stenosis, pelvic fracture, chronic radiation proctitis, and vaginal stenosis. Female patients should be encouraged to use a vaginal dilator. So let us write down the radiotherapy side effects. So radiotherapy side effects. So we have short-term side effects and long-term side effects. Short-term and long-term side effects. Short-term side effects: dermatitis, anal swelling and pain, frequency and urgency, and defecation, nausea, weakness, vaginal discomfort and discharge. Nausea, weakness, vaginal discomfort and discharge. And these short-term effects, they improve after radiation stops. And the long-term side effects are anal stenosis, pelvic fracture, chronic radiation proctitis, vaginal stenosis. So these are the long-term side effects, and female patients should be used to encourage vaginal dilators. Should be encouraged to use a vaginal dilator. Use vaginal dilator. So these are the side effects. So here we have a algorithm for evolution of management of anal cancers. So combined pre-op radiation and chemotherapy for squamous cell carcinoma of anal cancer was given, which was the Negro protocol. Radiotherapy should be the initial treatment in anal carcinoma. It was done in 1989. It was a Swedish study. Then came the use of mitomycin C as a definitive chemoradiotherapy regimen for anal cancer, and particularly with large primary tumors. This was in 1996. Then combined chemoradiotherapy is better than radiation with significantly improved local regional control, rate and reduction of the need for colostomy. Phase 3 trials were there 1997. And then induction chemotherapy with cisplatin based therapy not only failed to improve disease-free survival compared with mitomycin based therapy, but cisplatin based therapy also resulted in significantly higher colostomy rate. This was in JAMA 2008. Okay. So there are some more long-term side effects, and radiation may affect fertility in both women and men. Patient should be informed about sperm and ovarian tissue banking. So sperm and ovarian tissue banking should be done. There may be dyspareunia and lymphedema. So decreased fertility. So what can be done? Sperm and ovarian tissue banking. Sperm and ovarian tissue banking should be done. Dyspareunia and lymphedema. Dyspareunia and lymphedema. Now, special considerations are intensity modulated radiation therapy. Utilizes detailed beam shaping, enabling precision in targeting tumor and sparing normal tissue. Compared with conventional 3D CRT, IMRT may spare the perineal skin, external genitalia and bladder, reduce toxicity to surrounding anatomic structures. So what does this do? Intensity modulated radiation therapy, IMRD, reduces toxicity to surrounding anatomic structures and preventing toxicity related delay in completion of treatment, thereby improving treatment outcomes. So a retrospective study was done in 221 patients with anal squamous cell carcinoma and treated with CRT between so and so. 44 patients received intensity modulated radiation therapy and 177 received 3D chemoradiotherapy. And the 2-year local recurrence free survival, distant metastasis free survival, colostomy free survival and overall survival 88%, 83%, 96% and 92% respectively in the IMRT group. And you can see 81%, which is lower, 88% higher. So metastasis, local recurrence free survival. So this data, it demonstrates no significant difference between the groups. So IMRT is intensity modulation radiation therapy according to this study is as equivalent as 3D CRT. So here we have a diagram. So this is external beam radiotherapy being given to a patient. So this is a management algorithm for anal cancer. Okay, so we need to know TNM staging before we continue further. So let us just look at the TNM staging of anal cancer, which is given over here. Okay, so TX is primary tumor cannot be assessed. T0 is no evidence of primary tumor. X is cannot be assessed. 0 is no evidence of primary tumor. TIS as usual is carcinoma in situ, also called Bowen's disease or high-grade squamous intraepithelial lesions. Carcinoma in situ is Bowen's disease, high-grade squamous intraepithelial lesions. It's ISL AIN 2 to 3. And we have T1, T2, T3 and T4. T1 is 2 cm or less in greatest dimension. 2 to 5 cm in greatest dimension, not more than 5 cm. More than 5 cm in greatest dimension is T3. And T4 is tumor of any size invades adjacent organs. Example, vagina, urethra, bladder. Direct invasion of rectal wall, perirectal skin, subcutaneous tissue or sphincter muscle is not classified as T4. So adjacent organs should be involved like vagina, urethra or bladder. And direct invasion of rectal wall, perirectal skin, subcutaneous tissue or sphincter muscle is not classified as T4. So nodal status is NX is cannot be assessed. N0 is no regional lymph node metastasis. N1 is metastasis in perirectal lymph nodes. Perirectal lymph nodes N1. N2 is metastasis in unilateral internal iliac and or unilateral inguinal lymph nodes. N3 is perirectal and inguinal lymph nodes and or bilateral internal iliac or inguinal lymph nodes. Then distant metastasis would be M1. So this is the AJCC cancer staging 6th edition. So let us remember the TNM staging, which is very important. So we have TNM staging. So TX is primary tumor cannot be assessed. Cannot be assessed. T0 is no evidence. No evidence of primary tumor. No evidence of primary tumor. T1 is tumor 2 cm or less in the greatest dimension. Less than 2 cm in greatest dimension. T2 is more than 2 cm but not more than 5 cm. 2 cm to less than or equal to 5 cm in greatest dimension. T3 is tumor more than 5 cm in greatest dimension. It's very simple, this TNM staging of this anal cancer. T1 is less than 2, T2 is more than 2 to less than or equal to 5, and T3 is more than 5 cm. T4 is adjacent organ involvement. Adjacent organ involvement, and adjacent organ would be vagina, urethra, bladder. So involvement of perirectal skin, important is that involvement of perirectal skin is not counted. So perirectal skin, subcutaneous tissue or sphincter is not T4. So perirectal skin, subcutaneous tissue and sphincter is not T4. So it must involve vagina, urethra or bladder, and these are the adjacent organs. So in lymph node status we have NX, it means cannot be assessed. N1 is perirectal lymph nodes. And there is also an N0. N0 means no evidence of disease. So N0 is no evidence whatsoever of primary or no regional lymph node metastasis. No regional lymph node metastasis. N1 is perirectal lymph nodes. N2 is unilateral internal iliac or unilateral inguinal lymph nodes. N2 is unilateral internal iliac and or unilateral inguinal lymph nodes and or unilateral inguinal lymph nodes. So unilateral N2 is unilateral internal iliac and or unilateral inguinal lymph nodes. N3 is perirectal and inguinal lymph nodes, both perirectal plus inguinal lymph nodes Number 2 is bilateral internal iliac and bilateral inguinal lymph nodes. Bilateral internal iliac, and third is bilateral inguinal lymph nodes. These are the N1, N2, N3. M0 is no distant metastasis. No distant metastasis. And M1 is distant metastasis. So here we have the complete TNM staging. Tx cannot be assessed. T0 no evidence of primary. T1 is less than 2 cm. T2 is more than 2 cm to less than equal to 5 cm. T3 is more than 5 cm. T4 is adjacent organ. Involvement vagina, urethra or bladder. And important is that perirectal skin involvement, subcutaneous tissue involvement and sphincter involvement is not T4. Then nodal status, Nx cannot be assessed. N0 no regional lymph node metastasis. N1 is perirectal lymph nodes. N2 is unilateral internal iliac and or unilateral inguinal lymph nodes. N3 is perirectal plus inguinal lymph nodes, bilateral internal iliac lymph nodes and bilateral inguinal lymph nodes. And metastatic status is M0 is no distant metastasis, M1 is distant metastasis. So we have seen the TNM staging. Now we can proceed with anal cancer. So let us see the algorithm for anal cancer. Anal cancer algorithm. So Tx, Nx, M1. This is obviously metastatic disease. So what we have to do is systemic chemotherapy. So for metastatic disease, we give systemic chemotherapy. Then we go for T3, T4 cancer. T3 to T4. T4 is adjacent organ involvement and T3 is more than 5 cm. T3 is more than 5 cm. T4 is adjacent organ involvement, that is vagina, urethra and bladder. So it is a T3 to T4 disease or node positive disease. So when we have this combination, we go for chemoradiotherapy 45 GY plus 9 to 14 GY booster. Next is T1 to T2 N0. T1 T2 disease N0. So T1 T2 would be less than 2 cm, and less than equal to 5 cm. So approximately up to less than equal to 5 cm and nodal negative status. So we give 45 GY over 5 weeks. And last is T1 lesion less than 1 cm in size and not involving sphincter. Not involving sphincter. Go for local excision plus minus CRT. So this is the algorithm for management of anal cancer. So when we have metastatic disease, we go for systemic chemotherapy. When there is T3 to T4 involvement or node positive involvement, so T4 would be adjacent organ involvement according to TNM staging, and T3 would be more than 5 cm of tumor. We go for chemoradiotherapy 45 GY plus 9 to 14 GY booster dose. And if we have T1 to T2 disease without nodal involvement, that would mean around less than or equal to 5 centimeter. We give 45 GY over 5 weeks. So here it was also 45 GY with some booster, and this is with over 5 weeks. And T1 cancer that is less than 1 centimeter, not involving sphincter. T1 is actually less than 2 centimeter, but according to this algorithm, if the lesion is less than 1 centimeter and it does not involve sphincter, local excision can be done along with plus minus chemoradiotherapy. So this is the management protocol for anal cancer. Let us see. So limited localized disease, stages 1 to 3, any T, any N, M0. Local excision can be used to remove some small tumors. So local excision can be used to remove small tumors, usually measuring less than 1 centimeter or half inch, that do not involve the sphincter. We have seen in the algorithm. In some cases, this may be followed with chemotherapy and radiotherapy, which is especially recommended in the setting of a positive margin. In the setting of a positive margin, we have to do chemotherapy and radiotherapy. Standard treatment for anal cancers that cannot be removed without harming the anal sphincter is radiotherapy combined with chemoradiotherapy. So, standard treatment for anal cancers that cannot be removed without harming the anal sphincter is radiotherapy combined with chemoradiotherapy. Current primary recommendation for treatment of non-metastatic anal cancer include chemoradiotherapy. Commonly used therapeutic drugs include 5-fluorouracil and mitomycin. So, chemoradiotherapy and commonly used therapeutic drugs. So, commonly used therapeutic drugs are 5-fluorouracil and mitomycin. 5-fluorouracil and mitomycin. 5-fluorouracil and mitomycin. 5-fluorouracil and mitomycin. Mitomycin plus 5-fluorouracil plus radiotherapy. This regimen consists of 5-fluorouracil 1000 mg per meter square per day delivered via IV continuous infusion on days 1 to 4 and 29 to 32. Maximum daily dose of 5-fluorouracil is 2000 mg per day. So maximum daily dose would be 5-fluorouracil 2000 mg per day. Then mitomycin 10 mg per meter square via IV bolus on days 1 and 29, maximum 20 mg per dose. Radiotherapy may be included in all stages of disease with a minimum 45 GY delivered over 5 weeks. Additional radiotherapy of 9 to 14 GY may be considered with patients with T3, T4 or node positive disease. So we have seen all of this in the algorithm. So let us write doses for fluorouracil. 5-fluorouracil. Doses 1000 mg per meter square per day. IV via continuous IV infusion. On day 1 to 4 and 29 to 32. This is 5-fluorouracil. And then mitomycin. Then mg per meter square via IV bolus. So this was IV infusion, 5-fluorouracil. Mitomycin is IV bolus on day 1 and day 29. So in metastatic disease commonly treated with cisplatin based 5-fluorouracil plus cisplatin chemotherapy. So let us add in this algorithm. It is commonly treated with systemic chemotherapy is cisplatin based. Five fluorouracil plus cisplatin. So cisplatin plus 5-FU. This regimen consists of 5 fluorouracil 1000 mg per meter square per day via IV continuous infusion. 5 fluorouracil 1000 mg via IV continuous infusion on days 1 to 5 plus cisplatin 100 mg via IV on day 2, repeated every 28 days. So next is cisplatin plus 5-FU, 5 fluorouracil. So this regimen would have 5 fluorouracil 1000 mg per meter square per day via IV continuous infusion on day 1 to 5 plus cisplatin is given as 100 mg per meter square via IV on day 2, repeated every 28 days. Repeated every 28 days. Patients with metastasis receive systemic chemotherapy have approximate survival rates of 60% at 1 year and 32% at 5 years respectively. Some patients with metastatic disease, surgical intervention may be required for relief of symptoms such as pain, bleeding or fecal incontinence. So survival rates. Metastatic disease, receiving systemic chemotherapy. So approximate survival rates are 60% at 1 year, 60% at 1 year and 32% at 5 years, which is respectable. Prognostic factors. The size of primary tumor and the presence of nodal or distant metastasis are the principal determinants of outcome. So patients with de novo tumors of more than 5 cm are at significantly increased risk of requiring an EPR. So patients with de novo tumors of more than 5 cm are at significantly increased risk of requiring an abdominoperineal resection with permanent colostomy, and such tumors are associated with inferior disease-free and overall survival. Male gender and HIV positive status may portend an unfavorable long-term outcome. Evaluation of treatment response. The mainstay in assessment of tumor response is clinical follow-up. Patients are evaluated by repeated physical examination of the anal area at approximately 8 to 12 weeks after completion of chemoradiotherapy. So when do we have to evaluate? Examination of anal area at approximately 8 to 12 weeks after completion of chemoradiotherapy. Repeat physical examination. And at 6 to 8 weeks intervals until resolution of any suspicious findings. So follow-up. Based on evaluation, patients are classified with respect to remission as follows. So there may be persistent disease, complete remission would be there, or progressive or persistent disease at 6 months. Okay, so let us note down how to do treatment response follow-up. So follow-up for treatment response. So repeat physical examination of anal area at approximately 8 to 12 weeks. So first follow-up would be there after 8 to 12 weeks after completion of chemoradiotherapy. radiotherapy. How many weeks? 8 to 12 weeks. And here we do complete examination of the anal area, and then at 6 to 8 week intervals. After that, so this is how we do follow-up. So now classification as per the follow-up with respect to remission. So persistent disease. Patients with persistent disease but no progression are followed closely to see if further regression occurs. Based on the Act 2 study, patients with persistent but non-progressive disease may be followed up to 6 months after chemoradiotherapy until determination of complete remission. So may be followed up to 6 months after chemoradiotherapy until determination of complete remission. So classification with respect to remission. Classification according to remission. Number 1 is persistent disease. And followed up to 6 months. Until determination of complete remission. So persistent disease would be that the disease is stable, no progression. Persistent disease mein there is stable with no progression. Disease is stable with no progression. Then number 2 is complete remission can be there. Patients with complete remission should undergo evaluation every 3 to 6 months for 5 years. So what's the rule? Evaluation after every 3 to 6 months for 5 years. So evaluation after every 3 to 6 months for 5 years. This should include DRE, endoscopic examination of the groin, CT scan of the chest, abdomen and pelvis, or PET CT. Same. Performed annually for PET CT is performed annually for 3 years in patients with slow disease regression and those who initially had locally advanced disease, T3, T4 or node positive cancer. Then third is progressive or persistent disease at 6 months. So if the patient has persistent disease at 6 months or progressive disease develops in the meantime, biopsy may be done to confirm cancer. Biopsy is recommended earlier in the setting of tumor mass progression or unsatisfactory response to treatment. However, unnecessary biopsy should be avoided to minimize the risk of soft tissue infection, tissue necrosis, or impairment of renal function. So if this is the case, then what we have to do is biopsy. Biopsy has to be done. Now salvage treatment. Approximately 10 to 30% of patients have persistent or recurrent disease. How many? 10 to 30% of patients have persistent or recurrent disease after initial chemoradiotherapy. Risk factors associated with failure of initial treatment include: risk factors would be HIV positive status, high TNM stage, interruption of treatment during CRT. So progressive disease is biopsied and restaged. Biopsy and restaging. Some studies recommend an additional radiotherapy of 9 GY rather than resorting to APR immediately. However, salvage surgery is generally recommended for persistent anal cancer. So, salvage surgery is generally recommended for persistent anal cancer. So, what we will do is a salvage surgery. Surgical treatment is based on the extent of the persisting tumor. Patients with very limited residual tumor may be able to undergo local excision. Larger residual disease should undergo salvage APR. So salvage surgery may have two options. Limited tumor. If the disease is limited, then what we can do is local excision. And if the extent of the disease is more large, what we will go for is salvage APR, salvage abdominoperineal resection. So very limited residual tumor undergo local excision, and larger residual disease should undergo salvage APR. Salvage APR is associated with 5-year local regional control in 30 to 77% of patients. Overall survival at 5 years ranges from 30 to 60%. Wound complications are common and may be seen in as many as 80% of patients who undergo salvage APR after CRT. In order to reduce wound complications, muscle flap reconstruction of the perineum may be considered. So wound complications को avoid करने के लिए reconstruction of the muscle flap, reconstruction of the perineum may be considered. Plus minus muscle flap reconstruction to avoid wound complication. Treatment of recurrent anal cancer. If anal cancer recurs locally after initial treatment, restaging is performed to rule out systemic metastasis. This includes restaging, CT chest, abdomen, pelvis, or PET CT based on institutional preferences. Local recurrence after CRT is commonly managed with salvage APR. Isolated recurrence in an inguinal node may be treatment with radiotherapy to the groin with or without chemotherapy. There is no history of previous radiotherapy to the groin. If isolated recurrence develops in an inguinal node, despite previous radiotherapy, inguinal node dissection may be performed without an APR. Treatment of HIV positive patients. HIV is associated with markedly increased incidence of anal cancer, most likely due to immunosuppression. So why is it common in HIV patients? Due to immunosuppression and HPV infection secondary to anal receptive intercourse. Initial treatment of anal cancer is CRT. However, certain factors such as patient CD4 count play a role in modifying the dose of radiotherapy. So patient CD4 count play a role in modifying the dose of radiotherapy. Dose ranges from 32 to 63 GY. Chemotherapy may be delivered in conventional dose regimens including fluorouracil combined with mitomycin or cisplatin. Studies have shown that patients with CD4 count of more than 200 have acceptable treatment-related toxicity and may achieve very good disease control. So if CD4 count is more than 200, then there is acceptable treatment-related toxicity. With patients have CD4 count of less than 200, they have a markedly higher incidence of treatment-related morbidities. This is not associated with decreased overall survival. Chemotherapy dose may need to be altered based on patients' blood counts. So this is the mitomycin plus 5-fluorouracil. If WBC count is less than 2400 but more than 1000, or if platelet count is more than 50,000 but less than 85,000, then the second dose of mitomycin is reduced to this much. If WBC count is less than 1000, or if platelet count is less than 50,000, second dose of mitomycin is reduced to 5 mg per meter square from 10 mg per meter square. So in less than 2400 but more than 1000, reduced to 7.5 mitomycin from 10. 10 is normally given, it is reduced to 7.5. So if it is 1000, then reduced to 5 mg per meter square, or less than 50,000 platelet counts. Day 28, if WBC count is less than 2400, chemotherapy is delayed for 1 week. Higher incidence of in situ anal cancer among homosexual and bisexual men irrespective of their HIV status. Data suggests that anal cytology in screening in these men every 2 to 3 years may be cost effective and yield benefits in life expectancy. So if a person is homosexual or bisexual, then anal cytology screening can be done every 2 to 3 years. Then we have a different topic of anal melanoma. So anal melanoma. Next topic would be anal melanoma. So it represents 1 to 4% of all anorectal malignancies. Third most common site for melanoma after the skin and retina. So skin and retina, and after that anal melanoma, accounting for less than 1% of all melanomas. So melanomas occur on skin and retina, then anal canal. It is most commonly seen in females, and the mean age of presentation is 60 years. Arise from the transitional epithelium of the anal canal, the anoderm, or the mucocutaneous junction. So anal melanoma, 1 to 4% of anorectal malignancies. Then third most common site of melanoma. So first is skin, second is retina, and third is anal canal. Third most common site of melanoma, and most commonly seen in females. Most commonly seen in females. And mean age at presentation. Mean age at presentation is 60 years. And arises from transitional epithelium of anal canal. Transitional epithelium of anal canal, that is the anoderm. Symptoms. The most common symptom of anal melanoma is bleeding PR. Let's go to symptoms. Most common symptom is bleeding PR. Bleeding per rectum, most common symptom. However, as in the setting of any other anal lesion, patient may present with pain, change in bowel habits, or tenesmus. Early lesions may be mistaken as thrombosed hemorrhoids. So you may mistake it as a thrombosed hemorrhoids. So other symptoms are pain, change in bowel habits, pain. So this change in bowel habits is important in diagnosing anal cancer, at least clinically. We must ask it in the history taking. Physical examination. A thorough physical exam including assessment of the groin should be done. And anal melanoma may be pigmented and either polypoid or ulcerated. Anal melanoma may be pigmented and either polypoid or ulcerated with raised edges. Satellite lesions may also be present. So on examination, anal melanoma is pigmented. It will be pigmented, either polypoid or ulcerated. Polypoid or ulcerated. And there will be raised edges and satellite lesions may be present. Histopathological diagnosis. The features resemble those of cutaneous melanomas. The features are of cutaneous melanomas. Majority shows a junctional component adjacent to the invasive tumor, which proves that the lesion is primary in nature. Majority shows a junctional component adjacent to the invasive tumor. Tumor cells express S100, HMB45, and melan A. Perineural invasion is an important prognostic factor. So, histopathological diagnosis. junctional component adjacent to the invasive tumor majority and expresses S100, HMB45 and melan A. So this would be found in the biopsy. S100, HMB45 immunohistochemistry, S100, HMB45 melan A, and perineural invasion is an important prognostic factor. Perineural invasion is important prognostic factor. Treatment. The overall prognosis of anal melanoma is dismal. 10 to 19 months survival after diagnosis. Only 10 to 19 months survival after diagnosis. Prognosis is very poor. Poor, and how much survival is there? 10 to 19 month survival after diagnosis. So melanoma does not respond well to chemotherapy or radiotherapy. It does not respond well to chemotherapy or radiotherapy. Thus surgery is the principal treatment when disease is localized. The extent of surgical resection is a matter of debate. Anal melanoma is very aggressive, and up to 35% of patients initially present with metastatic disease. 35% of patients initially present with metastatic disease. So it's a aggressive disease, aggressive cancer. 35% present with metastasis. And does not respond well to chemotherapy or radiotherapy. Does not respond well to chemotherapy or radiotherapy. Surgery is the principal treatment if localized. So surgery is the principal treatment if localized. Tumor more than 1 centimeter are unlikely to be cured by any type of treatment. Some authors claim that APR is the first choice of treatment, particularly for patients with small tumors and no evidence of nodal metastasis. However, as most patients with anal melanoma die of distant metastasis, major operative intervention like APR may not offer a survival advantage. Most patients with anal melanoma die of distant metastasis, so any major operative intervention like APR, abdominoperineal resection, may not offer a survival advantage, and some authors prefer local excision as initial treatment for melanoma. Melanoma of anal canal is sometimes detected as an incidental tumor when local excision is done for hemorrhoids. Okay, so melanoma, this is important actually. We can send hemorrhoidal tissue for HP as an incidental tumor when local excision is done for hemorrhoids. If R0 resection is achieved during local excision for hemorrhoids, patients do not need further intervention and have shown acceptable cure rates. So if R0 resection is achieved during local excision for hemorrhoids, patients do not need further intervention and have shown acceptable cure rates. Palliative local excision should be considered for patients with local symptoms due to anal melanoma. So surgery is the only option if it is localized. So anal melanoma is complete. Then we have anal margin squamous cell carcinoma. So the next is anal margin squamous cell carcinoma. margin squamous cell carcinoma. Anal margin begins at the anal margin. It begins at the margin of hair-bearing perianal skin, extending onto the perianal skin for a 5 cm radius. SCC at the anal margin behaves like any other SCC of the skin and drains into the regional lymph nodes. Such as the inguinal nodes. Anal margin SCC accounts for 1/4 to 1/3 of all anal squamous cell carcinoma. Anal margin generally presents in patients between 65 and 75 years of age. So there is no gender predilection. 65 to 75 years presentation. Like any other anal diagnosis is delayed because of non-specific symptoms and difficult division. Most common presentation is symptomatic mass in the perineal region. Most common presentation is a symptomatic mass in the perineal region. So most common presentation is mass in the perineal mass or persistent pruritus. Perineal mass or persistent pruritus. Any person with persistent pruritus in the perineal region should be thoroughly examined for a perineal mass. Suspicious lesion should be biopsied. Should be thoroughly examined for a perineal mass and suspicious lesions should be biopsied. A thorough exam including assessment of the groin should be performed in patient with renal canal tumors. The relationship of tumor to the anal sphincter must be ascertained. Staging, CT of chest, abdomen and pelvis should be performed to rule out distant metastasis. Lymph node involvement. Studies have shown that the chance of lymph node involvement in a T1 lesion is extremely low. Chance of lymph node involvement in a T2 lesion is 24%. Chance of lymph node involvement in a T2 lesion is 24% and has high as 67% in a T3 lesion. So management would depend on size of tumor, lymph node involvement and sphincter involvement. So for a T1 N0 lesions, so T1 has lymph node involvement is extremely low. No sphincter or lymph node involvement. Preferred treatment is wide excision with a 1 cm margin. There is no sphincter or lymph node involvement. When possible, the defect may be closed primarily. However, a large defect may require a VY advancement flap or a skin graft. If the defect cannot be closed with an advancement flap, a pedicle flap may be necessary. Then T2 N0 lesions. Early T2 lesions may be treated with surgery if no lymph node involvement is present. However, advanced lesions may be treated with CRT. So early T2 lesions may be treated with surgery if no lymph node involvement is present, and advanced lesions may be treated with CRT chemoradiotherapy. If the chances of occurring lymph node involvement is higher, surgery to achieve a clear margin may result in an unacceptably large defect. T3, T4 or lymph node positive lesions, CRT protocols similar to those given for renal and squamous cell carcinoma are used. Inguinal lymph nodes are included in CRT. T3 and T4 inguinal node positive lesions should receive radiotherapy to the pelvis. So let us note down the treatment and lymph node involvement status. So lymph node involvement, T1 में extremely low, in T2 24% chance, and in T3 67% chance of lymph node involvement is there. Then management will depend on size of tumor, lymph node involvement and sphincter involvement. So management depends on size, lymph node involvement and sphincter involvement. So if it is a T1N0 lesion and there is no sphincter or lymph node involved, then what you can do is wide excision with 1 centimeter margin. That is what we can do. And defect may be closed primarily, and a large defect may require VY advancement flap or a skin graft. So this is for T1N0. Then T2N0. If early, then surgery can be done. If no lymph node involved, and in advanced, CRT. Then finally T3 T4 are lymph node positive. T3 T4 lymph node positive, we have to do CRT. So this is the management algorithm for anal margin squamous cell carcinoma. So these are the histopathological slides of anal melanoma. As always, only histopathologist can tell what these slides hold. Anal margin squamous cell carcinoma T1 or early T2. If no sphincter and lymph node involvement, preferred treatment is wide excision with 1 centimeter margin and reconstruction of defect. And if more, then chemoradiotherapy similar to anal canal squamous cell carcinoma. Then we have anal adenocarcinoma. So next topic is anal adenocarcinoma. Let's begin with anal adenocarcinoma. So anal adenocarcinoma is the primary mucinous adenocarcinoma of the anus. Is a rare malignancy. It's a rare malignancy. What is rare? Primary mucinous adenocarcinoma of anus is rare, accounting for 93% of anal canal cancers. Most anal adenocarcinomas originate from the colorectal zone in the upper portion of the anal canal or from the glandular cells of the ATZ mucosa, anal transition zone mucosa. Adenocarcinoma of the anal canal can be categorized based on the origin. So we have colorectal type adenocarcinoma. Macroscopically and histologically, these lesions are indistinguishable from ordinary colorectal adenocarcinoma. So these are colorectal adenocarcinoma. However, they carry a higher risk of nodal disease. Along the inguinal and femoral nodal chains. Immunohistology shows positivity for cytokeratin 20 and CDX2 and negativity for CK7, which is compatible with colorectal subtype anal adenocarcinoma. Adenocarcinoma within an anorectal fistula can also occur. Developmental or acquired due to inflammatory conditions such as Crohn's disease, and adenocarcinoma of the anal glands. This diagnosis is given if the tumor is primary to the anal canal and centered within the wall of the anorectal area without a pre-existing fistula and without surface mucosal dysplasia. Irrespective of the extent of mucin production, anal gland adenocarcinoma is CK7 positive. So let us categorize the anal adenocarcinoma on the basis of origin. So on the basis of origin, anal canal adenocarcinoma. So we have colorectal type, within an anorectal fistula, and adenocarcinoma of the anal gland. Adenocarcinoma carcinoma of anal glands. So colorectal type is CK20 and CDX2 positive and CK7 negative. Then adenocarcinoma of anal glands is CK7 positive. So clinical features and diagnosis में presents with symptoms similar to those of any other anal mass. Thorough physical examination and biopsy are required to confirm the diagnosis. Prognostic factors: T-stage, end-stage, histologic grade and treatment modality. Management: due to rarity of this disease, very few studies have been published reporting on management of anal adenocarcinoma. So there is no clear-cut management. Management options include local excision, radical surgery, APR with or without chemotherapy, or CRT. Historically, APR was the preferred treatment. However, with recent advances in CRT, a combined modality treatment including APR plus adjuvant CRT is considered optimal. So in management, current modality would be APR plus adjuvant CRT. Abdominoperineal resection with adjuvant CRT. Biologicals. So squamous cell carcinoma of the anus commonly overexpresses EGFR. Squamous cell carcinoma of the anus commonly overexpresses EGFR. Factor receptor EGFR and KRAS mutations appear rare. By this, the potential role of EGFR inhibition was supported by partial remission, minor remission, or no progression in 5 patients with wild-type KRAS anal cancer treated with either cetuximab as a single agent or cetuximab with irinotecan. So, according to this study, the authors concluded that cetuximab-based treatment can be used in patients with metastatic KRAS wild-type anal cancer after failure of cisplatin 5-fluorouracil-based therapy. So, the authors have concluded, and this table tells about the preferred treatment. Recurrent squamous cell carcinoma, local recurrences after treatment with radiation therapy and chemotherapy are treated with salvage APR. Anal melanoma, local excision, anal adenocarcinoma, combined modality treatment including APR with adjuvant CRT to optimal treatment. So this completes our chapter, our study on anal cancer. And here we have the notes. Already. And thank you all for studying with me.